Yes, I think this was a terrific trial that was sponsored by Merck, uh, based on the original observations that anti-PD-1 drugs work really well for microsatellite unstable tumors, specifically the most common being colon cancer, but then there are things like endometrial cancer and other MSI-High cancers. So this trial was really to put the drug into first line. And it was a global randomized trial looking at about 300 patients randomized to single agent pembrolizumab given every 3 weeks versus physician's choice of chemotherapy. And I think that was good because that allowed for different countries to give different chemotherapy and different biologics. And the largest, the split for chemotherapy was mostly FOLFOX, a little more FOLFOX than FOLFIRI. It was like 55-45, and 70% of patients also received bevacizumab in the study. So the primary endpoint was PFS and overall survival. What we got the report of at this meeting at the ASCO plenary session was the PFS differences between starting with chemo or starting with an anti-PD-1 drug, in this case pembrolizumab. And the overall survival data will take us a while to get, as waiting for people to eventually die. But a lot of the chemo patients got, or I would think almost all got, pembrolizumab second line, so there may not be a big difference in overall survival. We'll see. So this is a well-conducted, well-balanced international trial. They screened a lot of people for a long time to get the 300. And then we waited a long time for the results because there weren't a lot of events. People were not progressing that fast. And I think the survival curves are very interesting because it was huge difference between the two arms, whereas the 1 year PFS was 55% of patients had not progressed on pembro compared to only 37% with chemo. And then at 2 years, it was 48 versus 20, so 50 versus 20% at 2 years. So a huge difference, and the hazard ratio for this was 0.6. So a really clinically and statistically significant difference for giving pembrolizumab to patients who have MSI-High colon cancer as first treatment. However, I have a caveat. We saw, especially in the gastric trials, this crossover phenomenon, or as some people have called it, the yin-yang phenomenon, where the chemo does better initially and then the curves cross. And we also saw that in this trial, whereas the crossing point is about 6 months. The chemotherapy did a little bit better initially than the pembrolizumab. And if you look at the actual response rates, what you see is that the progression rate on pembro was almost 30% compared to 12% on chemo. So you eventually progressed on chemo, but there were a lot of early progressions on pembrolizumab. So I think one of the key things coming out of this is that, yes, pembro is the answer for most of the patients, but a third of the patients don't do that well and progress early. And what does that mean? So we don't know exactly who those patients were. I hope we'll see more data coming out for Merck on that early progressor group in the pembro arm. There's some hint that it could be KRAS mutated patients because they didn't seem to benefit as much in the forest plot that was presented, or perhaps people who have had high tumor burden or more symptomatic. We don't know these things. But overall, it's a very good benefit, almost twice as good PFS for treating with anti-PD-1 initially. And then the other question is, would it be better to give anti-CTLA-4 drug in addition to the anti-PD-1? checkmate trials of Nivo and Ipi are not, versus Nivo alone aren't randomized, but they look like a higher response rate and a better waterfall plot for the combination. So maybe the right answer is people ought to be getting Pembro plus an anti-CTLA-4 up front, and then you'd have fewer progressions. I don't know. That's another option. But these are some of the questions it raises